Our next speaker is Dr. Ghita Harifi, consultant rheumatologist and adjunct assistant professor at Mohammed bin Rashid University of Medicine, UAE. Dr. Harifi has extensive experience in musculoskeletal ultrasound and rheumatological imaging, contributing to advancing clinical practice and training in this field.
Her talk, titled Shoulder Anatomy, will highlight key anatomical landmarks essential for effective ultrasound assessment and interpretation. Please join me in welcome Dr. Ghita Harifi.
I'd like to start by thanking the PCR organizing committee and the ultrasound organizers for inviting me to take part in this ultrasound workshop. I've been wanting to come to Pakistan for the last 4 or 5 years and to be part of the PSR, but for various reasons this couldn't happen until now. So I'm incredibly delighted to be here today. So I have been given the task to talk about ultrasound shoulder, or to introduce you to the ultrasound of the shoulder. And I know that it's not an easy task, not because it's any difficult, but because I think for all beginners in ultrasound, ultrasound examination of the shoulder is portrayed as one of the most difficult ones. So it might sound a bit intimidating in the beginning, probably due to the complexity of the anatomy, the role of, the different patient positioning, but today we'll try to make it as simple as possible. I do a lot of ultrasound shoulders scanning in the clinic, and I must say that I really enjoy it. Mostly also because in many situations, it saves you from ordering MRIs and waiting for reports of MRI. You have an immediate answer of for the shoulder pain of your patient. So it's extremely rewarding. It's probably one of the most rewarding scans that you would do, and you would see that when you start scanning the shoulders yourself. So let's start without further ado. I have no disclosures for this talk. This is my agenda. I'll have to start with some anatomy, and I've been repeating this in the stations. You can't do ultrasound if you don't like anatomy. You have to revise your anatomy. It's a must. We can't do without it. So sonoanatomy comes from the knowledge of anatomy, of basic anatomy. We'll talk about we'll say a word about patient positioning, and then we'll spend some time on the standard scans of the shoulders, according to EULAR guidelines, and then we'll take a glance on shoulder pathology. So let's start with the anatomy, and in the anatomy of the shoulder, obviously, usually we talk about bone and joints, ligaments, and bursa, but when it comes to the shoulder, we'll be essentially talking about the rotator cuff, as you know. So shoulder is complex. The shoulder, we call it, by the way, the shoulder complex. It's complex because it's not one joint. It's basically a complex of 3 or 4 joints, according, to the authors. The shoulder is a group of structures that connects the upper extremity to the thorax and the neck, and it consists on the glenohumeral joint, the acromioclavicular joint, and from here to the sternoclavicular joint. So you have 3 joints. It's a complex of 3 joints, to which we add a non-anatomical joint, I would say, what we call the scapulothoracic joint, which is, stricto sensu is not a joint because there are no, bones, but functionally speaking, this is a joint that allows the movement of the scapula against the thorax. So it's this complex that we call the shoulder. And when it comes to scanning, we'll have to keep this in mind, and we shouldn't be stopping at the scanning of the glenohumeral joint. Now, shoulder stability is maintained by several ligaments, but we must remember that the shoulder is a very mobile joint. So unlike the hip, it's a very shallow socket. So, and the stability is mostly maintained by ligaments, but also the rotator cuff. it's an active stability that relies on the rotator cuff muscles and tendons. So in the basic course, we don't spend much time on ligaments, I must say, and I know that this is supposed to be a basic course, but I like to give a flavor of what it is to see ligaments on ultrasound when you scan in ultrasound. So basically, the most important ones are primary glenohumeral ligaments, with the superior, middle, and the inferior bundles. There are other important ligaments. Other key ligaments include the coracohumeral ligaments and the coracoacromial ligament and coracoclavicular ligament. During the scanning technique, we will probably point to one or two ligaments to show you, and not specifically the coracoacromial ligaments, and I'll show you why it's important to localize it. The bursa, and the most important bursa in the shoulder is what we call the subdeltoid subacromial bursa. In fact, these are two bursas, one below the deltoid, that comes just below the deltoid, and one below the acromion, but they are communicating, and therefore we consider that it's the same bursa. In other words, when you're scanning and you start seeing the bursa, you will have to follow the bursa. If you're coming from the acromion, you have to go to the deltoid, and if you're doing it starting from the deltoid laterally, then you'll have to go and follow this bursa also, in the proximal part. So, and then we come to the most important part in the anatomy of the shoulder, which is the rotator cuff. Now, the rotator cuff tendons and muscles are important for the shoulder stability. So, as a sonographer, what we need to remember is that when I go on the posterior aspect of the shoulder, what tendons am I supposed to see? So basically, to keep it simple, your infraspinatus, if you're posterior, so you'll have the infraspinatus tendon that comes and inserts on the greater tubercle as well, and the teres minor. The supraspinatus, which starts from the superior part of the scapula, will go more laterally and insert on the superior part of the greater tuberosity. Sorry. If we go, so this is when you look. This is a posterior aspect. If you look anteriorly, then you will be seeing the subscapularis tendon that inserts on the lesser tuberosity, and then you will have more laterally, the supraspinatus that comes, which is one of the most important tendons, obviously, to scan, which comes to the superior part of the greater tuberosity. On top of these tendons come the long head of biceps, which is part of the joint from this intra-articular part in here, and which has a groove that you see between the lesser and minor tuberosity, and which is covered by a ligament called the transverse ligament. So this is basically the anatomy of the shoulder. Let's talk about the patient positioning. Now, if there is an anatomical area where the scanning or the patient position is key, it's the shoulder. So this is one of the areas that you will have to scan while the patient is seated, basically, ideally on the revolving stool, so you can move, the patients. Otherwise, you will be moving, because you will have to be facing the patient when you're scanning the anterior aspect. You'll have to go laterally, you have to scan superiorly, and you have to also go on the posterior aspect. So there should be some mobility. If it's not you, then the patient. So a revolving stool would help with that. Regarding the arm positioning, it will change as you scan, because each tendon has its preferred position, arm position, and we will see that shortly. The probe placement and scanning also will depend on the tendons. And then, most importantly, this is an anatomical area where dynamic examination takes the major importance. So it's very important, if you scan a joint without moving scan a shoulder without moving it, then you're missing something. Okay, so the basic thing that we'll have to learn today is how to look, for example, for an impingement, a subacromial impingement, which is one of the most common causes of shoulder pain in the clinic. Now, like I said, for the patient positioning, you have to be able to scan anteriorly. You have to move and come on the top, to scan the superior aspect, and you have to be able to move laterally. The only axis where we will need the patient to be laying down is probably the axillary axis, where here the patient is lying down and you can, access the axillary area. Now, let's move to the standard ultrasound scans of the shoulder, and we'll start with the anterior scan. So, and like I said, let's make it simple. When I come to the anterior scan, I have to ask myself, what are the structures that I will be able to scan? There are many. I group them here in tendons and bursa, in joints and ligaments. However, most of the time, what you are required to do and to scan is 2 tendons and 1 bursa, basically on the anterior aspect. So there are 2 tendons, which are the long head of biceps and the subscapularis tendon that comes on the anterior aspect. And then there is 1 bursa, or 2 bursas, if you consider that subacromial and subdeltoid are 2 bursas. And regarding the joints, remember, on the anterior aspect, you do have also the sternoclavicular joint. So that's also something that you will have to scan. But also, we will be able to see the anterior recess of the glenohumeral joint. This is a very tiny and tight axis of the joint that we don't use too much in practice, but it is important to visualize it. And then the ligaments. And like I said, in a basic course, usually we don't spend time on ligaments, but I would at least like to show you the coracoacromial ligaments, because this is an area of impingement. This is an area where we look also sometimes for impingement. So, anterior aspect, long head of biceps. Now, I would like to mark a pause here to tell you about how we scan these tendons and the terminology. And from now on, I would like us to stop calling it longitudinal and transverse scanning, okay? The reason being is that when you scan tendons, you're not always, when you see longitudinal, and usually you refer to the position of your probe, it's not necessarily the longitudinal part of the tendon, right? Because these tendons have different orientation. So basically, for tendons in the shoulder and tendons in general, let's use the terminology of long axis, short axis. And then we know that we're referring to the tendon orientation and not the position of the probe, because it can be misleading sometimes. So long head of biceps, this is a short axis. And let me tell you that this is the recommended first scan ever. And for me, I've been scanning the shoulders for 15 years. This is how I start. The starting point for me is to look for the long head of biceps. How do we do that? Patient is seated, the palm up position, okay? So the elbow is 90 degrees and you're on palm up position. You will have to do a bit of rotation to see the long head of bicep, but this is basically the first position. And you start with a short axis, okay, transverse axis, the short axis of the tendon. You look for long head of biceps. You're going to be, this is your reference. You start from there, the starting point. And this is the view that you expect. You see the tendon, transverse or short axis of the long head of biceps in its groove made of the greater tuberosity and lesser tuberosity. And on the top of it, you have a ligament that we call transverse ligament, okay? On top of it comes the deltoid muscle. So this is basically the first scan, short axis of long biceps. So this is how it looks like, and this is the position of the probe. And like I said, we'll have to move to do a bit of rotation to see the long head of biceps. Now, once you localize the long head of biceps, and the other point which is important here is that when you do a long axis, you don't stop at, sorry, I'm going to just put this. You don't stop at this view, but you sweep and you go up and down, you go proximal and distal, because a tendon is not just one view, the tendon is quite long. So you go, and why is this important? Because some tenosynovitis, early tenosynovitis, will be visible on a very tiny part of the tendon, and if you stop at the first scan, you might miss it. So transverse view is up and down, we sweep up and down. Now, from there, you move to the long axis, you just change the orientation of the probe, and here you see the long axis of the tendon. This is a good view to appreciate the echogenicity and the quality of the tendon, and this is how it looks like. So, long axis position. Now, rotator cuff interval view is something that you will hear about. I would like just to mention it quickly. So this is basically the space through which the long head of biceps passes as it leaves the glenohumeral joint. It's called rotator cuff interval, and it's basically a view that allows you to see the supraspinatus, the long head of biceps, and the subscapularis with two ligaments in here. Okay, so we can see that also in the stations. Now, we said the first tendon was the long head of biceps, second tendon is subscapularis in the anterior aspect. Subscapularis, again, we start with the short axis. It's, so long axis, so see, now it's a long axis, but the position of the probe may leave you at the impression that this is a TS view. It's because of the position and the orientation of the tendon. So it's a tendon that comes all the way from medial to the medial part to the lateral part, and so to go longitudinally, this is a longitudinal view, you have to follow the fibers. So for the subscapularis, you will have to do a rotation. It's a tendon that tends to be a bit medial, okay, and it hides a little bit medially. Unless you do a bit of rotation, turn a rotation like this, you won't be able to see it. So same position as long head of biceps, but with a bit of more rotation to expose it. So, and then once you localize it, you move to a short axis to appreciate the tendon, look for, tendon tear and calcifications and other abnormalities. Now, two tendons, then one bursa. This is a longitudinal scan of the subacromial subdeltoid bursa. For the bursa, the position is similar to the position of the supraspinatus. We will come to the supraspinatus. You will ask the patient to put the head on the back, and so this is basically to uncover the supraspinatus, and you will see the bursa, the subdeltoid bursa starts here. It's between the supraspinatus and the deltoid, and then you follow this bursa till the subacromial part. So basically, this was a long axis, this is a short axis of the subacromial subdeltoid bursa. Again, it's positioned between the supraspinatus and the deltoid, and when it's inflamed, it's distended. You can see a large amount of effusion at this level. Now, I told you, so we talk about, I probably skip the ligaments in here, and we can show them in the stations, in the hands-on sessions. The coracoacromial ligaments is something I always check during my scans, because this is, like I said, when you check the subscapularis, you go a little bit more medially, and this is where you see the longitudinal axis of the coracoacromial ligaments, and you can do a dynamic examination by doing a passive rotation while examining. So this tendon that comes in here is the subscapularis, and you see this is the coracoacromial, the ligaments basically between the coracoid and the acromion. Now, it's an area of sometimes of impingement. We see sometimes in athletes and tennis players, etc. Sometimes some impingement at this level. Now, so this was for the tendons, and for the bursa, anterior aspect will allow you to see two joints. The sternoclavicular, like we said, and the anterior recess of the glenohumeral joint. So this is basically the position Again, external rotation, and you put the probe in this position, and the anterior aspect, recess of the glenohumeral joint is quite deep in there. These are the landmarks. So when you put the subscapularis and you do a full rotation, you go a little bit deeper and you will see the recess, and you can start seeing the anterior labrum in there. And then the last scan would be the scan of the sternoclavicular joints and the anterior aspect. It's a joint to not neglect, especially in inflammatory arthritis. Psoriatic arthritis patients tend to have a lot of inflammation in here. I saw recently a patient with spondylarthritis with a massive synovitis in the sternoclavicular joint as the unique presentation initially, and then we discovered the sacroiliitis and so on. So a joint to scan. So that was for the anterior aspect. The superior aspect is easy, one joint, acromioclavicular joint. Don't forget to scan the acromioclavicular joints. This is basically on the top to explore, and then you you put the probe on the top, you actually feel the bone landmark, and you put the probe on it, and this is the view you get. So you see clearly the capsule, you see the joint line, you see the capsule. The capsule is distended when you have an effusion sometimes, and this is an area where you see a lot of osteoarthritis changes in elderly. Lateral scan. In the lateral scan, basically, you have something very important. Okay, one of the most important tendons to check in the rotator cuff, which is the supraspinatus. Okay, and this is also the axis or the aspect where we're going to be looking for subacromial impingement. Supraspinatus tendon, so this is a view of the long axis of the tendon. This is how it looks like. So basically, you go a bit laterally, and you know that this is a tendon that will insert on the greater tuberosity, okay, on the top of the tuberosity. So you follow the tuberosity and you see the insertion, and you appreciate, the tendon, the echogenicity, calcifications, a tear, and you look for, this was the short axis, long axis to the supraspinatus. You tilt the probe, you go to perpendicular plane, and this is the view that you get. Now, so to check for an impingement, you have to determine, you have to see the acromial origin of the deltoid muscle. So you'll have to go laterally, recognize the acromion, and then the deltoid, departure from here, the supraspinatus will be just below. So basically, it's the landmarks here, or the bony marks, will be the acromion, the humerus, and then the deltoid. And and here you do your dynamic examination by passively or actively actually moving the arm, or doing an abduction, and while keeping your probe on the acromion to see if there is any impingement at this level. So now, so we've done the anterior, the superior, the lateral aspect, and now we're left with the posterior scan. Posterior scan basically will check the obviously the posterior recess of the glenohumeral joint, and check the posterior labrum. So this is the position. You go posteriorly. You see the glenohumeral joint in here, and you follow it up. If you go a little bit distally, you can see the spinoglenoid notch as well, and basically this is where you see if there is any effusion, any synovitis, any changes in capsulitis, for example, changes for capsulitis. So you can see here in the posterior aspect, you will appreciate also the infraspinatus tendon. So the infraspinatus tendon will also inserts on the greater tuberosity, and so basically you follow the humerus here. This is the infraspinatus. It's quite superficial if you go a little bit up once you identify the joint, and you go long axis and short axis, which will allow you to appreciate the echogenicity of the tendon and if there are any abnormalities. I will just skip this one. And the longitudinal scan of the glenoid notch, it's something that we do, when you check the glenohumeral joint. If you go a little bit more, proximally, you'll be able to see this notch. It's probably something that you won't be doing every day in the clinic, but I just, yesterday, just before I flew to Lahore, I saw a patient with a severe pain in the suprascapular area, and when I scanned, there was a ganglion at this level. So there was basically a compression of the suprascapular nerve that was causing the pain. So you can actually make easy diagnosis by scanning. So the last axis would be the axillary scan, which is basically to appreciate the axillary recess of the glenohumeral joints, and which takes more importance probably also for when you're doing vascular scanning for giant cell arteritis to try and identify any abnormalities of the axillary vessels. So this is a summary of the standardized scan of the joint of the shoulder, and I would like quickly to take a glance on shoulder pathology with you. What we can see on while scanning ultrasound. So we started with the biceps. Bicipital tenosynovitis is quite common in degenerative pathology, but such an aspect which is with the high grade power Doppler signal is something in a context of PMR, for example, polymyalgia rheumatica, that should be interpreted carefully. This is very inflammatory bicipital tenosynovitis. So if it's bilateral, and if your patient has symptoms of PMR, if he's falls in the category, the age category, then think PMR. This is now considered as one of the criteria. Supraspinatus full thickness tear gives you things like a naked tuberosity, you see here, absence of tendon in here, and sometimes it gives you this aspect of a sagged peribursal fat sign. We call it sag peribursal fat. You see that the supraspinatus, something is missing in the supraspinatus, and because of the fat, it gives you the fat takes over and it gives a sag peribursal fat sign. These are signs of full thickness tear. You can have partial thickness tear in the supraspinatus. The supraspinatus pathology is basically the commonest pathology in the shoulder. So you spend time scanning the supraspinatus, it's important. You can see deltoid bursitis. This is quite a rare form of chronic subdeltoid bursitis with rice bodies, something that we can see in infectious bursitis, TB, tuberculosis bursitis, but also in rheumatoid arthritis. And large amount of vasculitis, large subdeltoid bursitis. These are things that you scan the joint, you see the bursa distended like that, and you have obviously the answer for the patient's pain, and you can put a needle immediately and aspirate, and you have an immediate relief of his pain. AC joint osteoarthritis, there is a lot to show you, but with this I'll have to stop. I think I have exceeded my time, and I would like to say shukran in Arabic and shukriya in local language. Thank you very much.
We will now continue our next hands-on training round for shoulder scanning. Participants are requested to make their way to the ultrasound stations for upcoming practical session.
Please gather promptly so we can make the most of this valuable learning time. You all are requested to move to the station that you have been allocated to. Our ushers are here to assist you in case of any queries.